I'm Dr. Vijaya Kumar here, head of the Department of Gynecology. Good afternoon, everybody. The urinary incontinence is defined. We'll discuss today the urinary incontinence. Then, urinary incontinence is defined as a complaint of involuntary leakage of urine. So, patient will not be knowing that there is leakage of urine. Without a knowledge, the urine gets leaked from the genital tract. The incontinence can be a sign or symptom which is complained by the patient or a condition diagnosed by an examiner. So before we know the incontinence of the urine, we must know the neurological background behind it and the neurological supply or innervation of the bladder. The micturition center lies in the anterior lobe of the brain, and mainly the neurological supply to the bladder arises from the thoracic 11 to lumbar 2 and sacral 2 to sacral 4. Here, the nerves come from the hypogastric nerve, that is a sympathetic nerve, and the under nerve is a pelvic nerve, that is parasympathetic. This hypogastric nerve is a sympathetic, whereas pelvic nerve is a parasympathetic, and under nerve, pudendal nerve, that is somatic nerve. So these are the various nerves supplying the bladder, and the drugs that act on the bladder are anticholinergic drugs. The site of action has been shown, and the smooth muscle relaxants that is on the bladder wall, and the calcium channel blockers also act on the bladder wall. And in urethral sphincter, alpha adrenergic antagonists act on the sphincter of the bladder. This is a nerve supply of the bladder, and the drugs, where do they act to control the incontinence. The coming to the differential diagnosis, and we must know what are the various types of incontinence. One is stress incontinence. So here mainly the incontinence of urine is divided into true incontinence and the false incontinence. The true incontinence, which occurs in the vaginal fistulas, uretrovaginal fistulas, vesicovaginal fistula, urethrovaginal fistula. Those are direct communication from the urinary tract to the vagina. They are called true fistulas, whereas the false fistulas are called stress incontinence is one, where the intrinsic sphincter dysfunction. Here in stress incontinence, intrinsic sphincter dysfunction plays a role, and the patient will have incontinence on coughing, sneezing, wherever there is rise in the intra-abdominal pressure. Then the urge incontinence. It is also called idiopathic incontinence or neurologic distress or hyperreflexia. Otherwise, it is overactive bladder. So then comes the mixed incontinence, that is stress incontinence as well as urge incontinence. That means the stress means whenever there is rise in the intra-abdominal pressure, the patient passes urine, and it is combined with urge means the patient will feel the act of micturition before she goes to the toilet. She passes urine. She'll have the immediate emergency to empty the bladder. Then comes the overflow incontinence with urinary retention. It is due to the obstruction or bladder hyporeflexia. This is overflow incontinence with urinary retention. Then, as I said, bypass incontinence. These are genitourinary fistulas. These are actually the true fistulas, wherever the rest of the incontinence comes under false incontinence. This is the true incontinence, that is bypass incontinence or genitourinary fistulas. Then comes the urethral diverticulum. The congenital urethral abnormalities, epispedias, bladder exstrophy, and ectopic ureter. These are the congenital urethral abnormalities where the patient can have incontinence of urine. Then coming to the functional and transient incontinence, the one is infection, pharmacological due to some drugs, and a restricted mobility. If the patient is immobilized from bed for a longer time, then the patient can have transient incontinence. Then dementia and delirium. These are some psychological problems where the women can have incontinence. The excessive urine production, as in diabetes mellitus, diabetes insipidus, resorption of the extravascular fluid, and as with the lower extreme edema, as lower extremity edema, the patient have excess urine production. These are the various conditions that are to be, these are the various false incontinences which we have to differentiate from the true incontinence. The urinary incontinence as a whole, the complaint of any involuntary leakage, as in stress urinary incontinence, the complaint of involuntary leakage on effort of physical exertion, on sneezing or coughing. As I said, whenever there is raise in the intra-abdominal pressure, there will be pressure over the urinary bladder from inside, and the patient will have the incontinence of urine, involuntary leakage of urine. That is stress urinary incontinence. Then ordinary incontinence, the complaint of involuntary leakage accompanied by urgency. The patient feels the act of micturition, but before she reaches the toilet, she passes some amount of urine. So she can't stop it till she reaches the washroom. So then the mixed urinary incontinence, the complaint of urinary leakage associated with urgency and also with exertion, effort, sneezing or coughing. Then posterior urinary incontinence, the complaint of involuntary loss of urine associated with change of body position. For example, rising from seated or lying position. So whenever a prolonged confinement to the bed, when the patient raises and sits, then she may pass urine. Or when she gets up from a lying position, she may pass urine. This is called postural incontinence. Then coming to nocturnal enuresis, complaining of involuntary urinary loss that occurs during sleep. While sleeping, the patient passes urine without her knowledge. The continuous urinary incontinence complains of continuous involuntary loss of urine. Generally, it occurs in genitovaginal fistulas, uh, urinary fistulas. Then, insensible urinary incontinence. Complaints of urinary incontinence where the woman has been unaware of how it occurred. That is insensible urinary incontinence. Then coital incontinence. Complaints of involuntary loss of urine with coitus. So when with the act of coitus, the patient may pass urine. That is called coital incontinence. Then overactive bladder or urgency syndrome. Urinary urgency, usually accompanied by frequency and nocturia, with or without urgency. Urinary incontinence. In absence of urinary tract infection or other obvious pathology, the patient may have urgency syndrome, overactive bladder. Then increased daytime frequency. The complaint by the patient who considers she voids too often by day. Then nocturia, the complaint that the individual has to wake one or more times to micturate. Then comes the urgency, the complaint of sudden compelling desire to pass urine that is difficult to defer or that is difficult to control is called urgency. So while taking history to diagnose what type of incontinence she has got, the history taking is very important. We must ask these questions. Do you leak urine when you cough, sneeze, or laugh? That shows that the patient has got stress incontinence. Do you ever have such an uncomfortably strong need to urinate that if you don't reach the toilet, you leak? Do you have such an unfortunately strong need to urinate that if you don't reach the toilet, you leak? That is shows if that the patient complains that she has got that, we can classify it as urgent continence. Then how many times during day do you urinate? How many times do you get up to urinate during night after going to bed? These are all the questions that you have to ask the patient in the history to come to a clinical diagnosis. Have you ever wet the bed? Do you leak during sexual course? It is postcoital incontinence. And do you wear a pad to protect your clothing? So that means because of the incontinence, the patient has to wear a pad. If yes, how often do you change the pad? That gives the history how much leak she is having, whether it is in the way of drops or excess urination. And it is only a few drops when it is damp or when it is totally wet. That depends. We can make out how much leak she has got. If she has got only drops, the pad will get damp. If it is a heavy leak, then it becomes totally wet. After you urinate, do you have dribbling or still feel the presence of urine in bladder? That is mean incontinent, incomplete evacuation of bladder. Otherwise, some amount of urine will be left even after dribbling. That you call it as residual urine. By doing ultrasound, we can make out how much residual urine is there in the bladder after the patient passes urine. Does it hurt you while urinating? That means it may be in the form of dysuria, mostly in urinary tract infections. The urination hurts when the patient urinates. Do you lose urine without the urge to go? So the patient will not have the urge to go, but there is continuous leakage of urine. What are the tests we have to do to come to a final diagnosis? By history, we can come to a provisional diagnosis from the symptoms. And the investigations, what we had to do is simple cystometry, measures the bladder pressure and volume, useful in patients with clear-cut symptoms. This we can do for the patients with clear-cut symptoms. The simple cystometry will help. For complex cystometry, the multiple parameters, bladder volume, filling rate, bladder pressure, abdominal pressure, and subtracted detrusor pressure. This will give this the complex cystometry, more accurate information on bladder function, most common type of urodynamic test, what we do commonly. Then uroflowmetry also can be done, measures flow rate with special electronic flow meters, useful for general impression of the voiding function. Then pressure flow combines complex cystometry with uroflowmetry. This measures the bladder pressure, abdominal pressure, subtracted diastolic pressure, and uroflow. This will when you do the pressure flow investigation, we will get all this information. Provides accurate means of differentiating diastolic contraction, straining, and pelvic relaxation as a mechanism of urination. Then then comes the leak point pressure. Using abdominal or bladder pressure, urethral resistance to abdominal strain is measured. Used for assessing the urethral sphincter action. To measure the urethral sphincter action, to know the urethral sphincter action, you must do for leak point pressure. Then comes the urethral pressure Profilometry. Using a dual transducer catheter, stimulation, bladder, and urethral pressure can be recorded. Used in assessing urethral sphincter function. This urethral sphincter profilometry, we can assess the ureteric sphincter function, whether sphincter is functioning all right or there is any weakness in the ureteric sphincter. Then electromyography. This is surface and needle electrodes to determine striated muscle activity of the pelvis, pelvic floor, or the anal urethral sphincters. Useful in patients with abnormal voiding patterns. So these are the various cystometry, complex cystometry, uroflowmetry, pressure flow, and leak point pressure and urethral pressure profilometry, and electromyography. These are the various investigations that we can do to come to a final diagnosis. Then, what are the indications for multi-channel urodynamic testing? In complicated symptoms and history, used when considering surgery for correction of incontinence or pelvic organ prolapse. Before surgery, we would prefer to do this investigation. Then underlying neurological diseases, urgent continence refractive to initial conservative therapies. In urgent continence, when we fail, when the patient fails to respond, then we have to do this investigation. Then there is a continuous leakage. There also we do multi-channel urodynamic testing. Then previous continence surgery and clinical findings do not correlate with symptoms. Elderly patient more than 65 years, we prefer to do multi-channel urodynamic testing. Then coming to management, first is neurosurgical management of urinary incontinence. This is behavioral therapy. So you must counsel the patient and do behavioral therapy to rectify most of the types of incontinence. Then fluid management. We have to reduce the fluid intake and you must assess what is the urinary output. Then bladder training. You must ask them to train the bladder to contract the bladder muscle and to hold the urine. That is called bladder training. And pelvic floor muscle training. That is biofeedback and vaginal cones. Vaginal cones are there. We'll put in the vagina and we ask the patient to do gripping of the vaginal cones with by contracting levatrine and the perineal muscles. Then, thus the pelvic floor muscles will be, the tone will be increased and the patient will be able to stop the incontinence of the urine. And functional electrical stimulation. This is the electric stimulation what will give an anti-incontinence pressure. So there are various specialties which can be used for incontinence. Pharmacotherapy. There are anticholinergic drugs which can be used to control incontinence. And sacral neuromodulations can be used to control incontinence of the urine. These are all the pharmacological and behavioral therapy and the pelvic floor exercises that we advise the patient to control incontinence. Surgical treatment of surgery urinary stress urinary incontinence. As I said, the stress urinary incontinence means whenever there is rise in the intra-abdominal pressure, the patient passes urine. So there are various surgical procedures that we can do, that is retropubic urethroplexy. That is, one is Birch-Calpo suspension, and second one is MMK surgery, Marchetti crank. Here we pull the abdominal aponeurosis from the abdomen. Then retropubically we bring those strips of rectus sheath behind the symphysis pubis, and we'll get, then we'll recroach vaginally, then we'll suture them in the mid-urethral region, so that the stress urinary continence control, and the bladder neck will be, mid-urethra will be pulled up. Then suburethral sling also we can put, and mere mid-urethral sling, that is, it may be retropubic, transobturated, and single incision. So these are the things. Mid-urethral slings, we put what is called tension-free vaginal tape. Tension-free vaginal tape, TVT. This will put a tape. There are specialized needles are there which you pass and put the tape without opening the abdomen. This is mostly a vaginal procedure. We must know the technique to pass those needles. We have got two needles, one for the right side and then for the left side. We have to put those needles and bring the mesh, ribbon type mesh, in the mid-urethral region. Then you can use urethral bulking agents. So these are the abdominal surgical procedure to correct incontinence. Anterior vaginal wall is mobilized. Two sutures have been placed on either side of the far lateral to the midline. Distal sutures opposite the mid-urethra, and they'll be tied. And this is also called, we can, there is other technique called Kelly stitch. This will put the stitches, will put the Foley's catheter, will put the, inflate the bulb. Then by pulling the Foley's catheter, then we'll be able to reach the neck of the bulb or the urethra. Where the bulb gets obstructed, that is the neck of the bladder. There we can put few stitches in the paraurethral tissues, and we can take the urethra, superficial part of the urethra, and plicate. We'll plicate it two sides, then we'll close the vaginal wall. This is called a Kelly stitch. So we shall deal in detail when we discuss stress incontinence. This is the urethra we are seeing. And this is where we have shown the Cooper's ligament. We are suturing the Cooper's ligament on both sides and bring the tie to the center so that we can create an angle at the urethra. These things we'll discuss in detail when we deal with the stress incontinence. This is how placement of mid-urethral sling in the sagittal view. This is A in the sagittal view. Then you see the thread lifting the mid-urethra and retropubic passage of mid-urethral sling. And the other picture is transobturator passage of mid-urethral sling. See, these are the three directions where we can pass the sling. Mid-urethral sling can be passed, what we have shown in the cystal view, retropubic passage of the mid-urethral sling, and the transobturator passage of mid-urethral sling. So coming to the medical line of treatment, pharmacological treatment of urgent incontinence, the various drugs are used. Oxybutylene chloride, Ditropan is an anticholinergic drug. used 15 to 30 milligrams daily. The side effects are dry mouth, blurry vision, constipation, tachycardia, drowsiness, and laziness. These are the various side effects. And the other drugs are oxybutylene chloride, ditropan, long acting. The drug type is the same anticholinergic drug, and the dose is 5 to 30 milligrams daily. And transdermal oxybutylene is a patch in the way of patch transdermal oxybutylene, and this is 3.9 milligrams per day patch. This is in the way of patch, not in the way of tablet. Toleridion, this is Retrol, anti smooth. It is a smooth muscle relaxant. So this dosage is 1.2 milligram twice daily, and a tolterodine long acting. This is Detrol LA long acting, and the dosage is 2 to 4 milligrams per day, once in a day. And transpium chloride. This is also anticholinergic. Antimuscular is the muscular relaxant, and 20 milligrams twice daily. And derifexin, Anablex, proprietary name, is anti-muscle selective tertiary amine. This is 7.5 to 15 milligrams daily. There are the various drugs, pharmacological agents, which we use for unurgent continence. So coming to the what are the causes of overflow incontinence? The neurological causes are spinal cord trauma, then excessive compression. Neurological causes are spinal cord trauma, cerebral cortical lesions, and diabetes mellitus, multiple sclerosis. The anatomical uh, causes of overflow incontinence are extrinsic compression, prolapse in ovum, and urethral masses will cause overflow incontinence. Coming to the iatrogenic causes, surgery, obstetric trauma, aesthetic, these will cause overflow incontinence. Certain infections, like infection of the bladder, cystitis, infection of the urethra, urethritis, and the drugs which can give rise to overflow incontinence are anticholinergics and alpha-adnetics. This can cause overflow incontinence. Then we'll come to stress incontinence. Stress incontinence is called genuine stress incontinence. Involuntary leakage of urine associated with stressful activity like coughing, sneezing, straining, other physical activities in the absence of destructive contraction, which she finds socially and hygienically unacceptable. So that is called stress incontinence. So it's as I said, it's an involuntary leakage of urine with stressful activities like coughing. Whenever the women coughs, sneezes, straining, or lifting heavy weights or other physical activities, then in the absence of destructive contact, which she finds socially and hygienically unacceptable. Coming to the urgent continence, maintained by urethral closure pressure, intravesical pressure minus intraurethral pressure, then involuntary urine loss may follow a strong desire or need to void, mainly due to destrosor muscle overactivity. So involuntary loss of urine occurs, and that is followed by a strong desire and need to void, mainly due to detrusor muscle overact. This is called urgent continence. Unconscious incontinence. No awareness of urinary leak results from neuropathic, neuropathic bladder due to retention of urine and overflow. This is a frontal section of the bladder, lower end of the bladder, and the urethra. These are the various muscles which control the sphincter. So, coming to some most common types of incontinence, this is overflow incontinence. Because of the overflow in the bladder, there is raised pressure inside the bladder, and the patient dribbles because of the blockage. Bladder unable to empty properly. So, that is overflow incontinence. Then coming to the stress incontinence, relaxed pelvic floor, increased abdominal pressure causes stress incontinence. Then the urgent incontinence, bladder oversensitivity from infection or due to neurological disorder. This is called urgent incontinence. Here we have seen in the bladder the causes of incontinence, detrusor overactivity, sphincter dysfunction, and pelvic floor weakness. These are the main causes of incontinence. That is, one is detrusor overactivity of the bladder, wall of the bladder, in the upper part, and sphincter dysfunction, where the sphincter doesn't function well, and there is weakness in the sphincter. And whenever there is weakness in the pelvic floor, that fails to control the sphincter mechanism of the bladder. This is how abdominal pressure. This is untreated, first one. Second, untreated. Here, the urethra is well much relaxed, and after treatment, it is acting well. It is able to retain the urine. Stress incontinence. Stress incontinence weakens the pelvic floor muscles. Pelvic floor sags and does not support bladder. So this is shown in the picture. Bladder neck collapses through pelvic floor and the stress incontinence occurs. And coughing, laughing, running causes rise in the intra-abdominal pressure, and urethra does not tighten. Small amount of urine leaks. This is due to the weakness in the pelvic floor. The mechanism depends mainly on internal sphincter at the neck of the bladder. So normally it can accommodate 20 centimeters of water. There is a pressure of 20 centimeters of water. When uretrovesical angle is more than 100 degrees. The stress incontinence is mainly due to the obliteration of the posterior uretrovesical angle. Angle is more, it must be more than 100 degrees. But when it becomes less than 100 degrees, posterior uretrovesical angle, then the stress incontinence occurs. When upper urethra and the bladder neck remain above lever triangles. When abdominal pressure is transmitted equally to the bladder leaf, these are the causes for stress incontinence. So these we have shown the urethral pressure, total bladder pressure, intensive bladder pressure, total bladder pressure minus abdominal pressure. This is the diagram showing how to measure the pressures in the bladder, in the abdomen. Atony or damage to the pudendal nerve during vaginal delivery will also cause stress incontinence. Bladder and neck descends below the lever triangle muscle and uretrovesical angle is lost. That means when it is less than 100 degrees, it must be more than 100 degrees the angle. But when it becomes less than 100 degrees, uretrovesical angle is obliterated, then the patient gets stress incontinence. When abdominal pressure transmits only to the bladder, reducing urethral pressure causes urinary incontinence. This is the pathophysiology behind stress incontinence. This is how what is a healthy pelvic floor. Here the pelvic floor has become weak pelvic floor. So the more chances for stress incontinence is there because of the weakening of the pelvic floor. Here also urethra, in first picture urethra is normal, urethral sphincter is normal, and in second picture because of the increased intra-abdominal pressure, the bladder contracts and the urine leaks. Contributing factors are vascular fluxus as well as longitudinal fibers of urethra maintain the tone during filling phase. The contributing factors for stress incontinence are the vascular plexus as well as longitudinal fibers of the urethra. Longitudinal muscle fibers of the urethra maintain tone during filling phase. Two loops of smooth muscles, lysosphincter. One pulls sphincter anteriorly, the other posteriorly, maintaining the uretrovesical angle at more than 100 degrees. More than 100. Tone of the lower triangle muscles, pudendal nerve, and pubovaginal fossa. These are the structures which maintain the urethra to be well angled. Whenever the triangulation is lost, there is loss of posterior uretrovesical angle, then the patient gets stress incontinence. Here the anatomy of the incontinence. Potential problems are muscle that support the bladder are weakened, uterus presses the bladder, atrophy of the tissue of the muscle due to loss of estrogen, especially when the postmenopausal women, the stress incontinence is more common due to the atrophy of the tissues and muscle due to loss of estrogen. And irritants and inflammation reduce muscle control. The injury due to childbirth or trauma will weaken the pelvic muscles, perineal muscles. Emotional legacy of trauma and anger. This is also contribute to the incontinence. How to manage primary clinical evaluation, detailed history, menopausal obese women with previous vaginal deliveries, complaints of passage of single spot of urine at the height of physical exertion, rule out local pathology of the bladder and urine, rule out organic neurological disease, like multiple sclerosis, teres dorsalis, others. Then major pelvic dissection of the uterus or rectum. This may denervate the sphincteric nerves and may cause loosening of the sphincter and incontinence of the sphincter, which will lead to stress incontinence. This is regarding the male, the penis where the bladder you can see. So coming to the examination, pelvic and speculum examination are must thorough neurological assessment. Pelvic supports and tone of the levator muscles are to be assessed. Urethral, uretrovesical junction mobility, assess senile vaginal changes. These are the examinations that are to be done on the patient. Coming to the investigation of the stress tests are patient's voids, urine, bladder catheterized, vestigial user is sent for culture. 250 ml of saline instilled into the bladder. Patient squats on pre-weighed absorbent pad. Asked to cough and strain. Then you take the weight of the wet pad. Urine leak noted. Patient strained in lithotomy position, absorbent weight, net weight gain more than 2 grams, indicator for stress incontinence. Then comes to the cotton swab stick test. We'll put cotton swab stick in the urethra. Initially, cotton swab will be parallel to the floor. On stress incontinence, angle of the swab stick will be less than 10 to 15 degrees. In general stress incontinence, more than 20 degrees commonly, 50 to 70 degrees, will be shown by the swab test and we fit into the urethra. Marshall and Bonnie's test. In patients with positive stress, absence of leakage of urine and bladder neck elevation indicate a beneficial outcome of surgery. So we'll put two fingers on both sides of the urethra and ask the patient to cough or sneeze. Two fingers are placed in vagina and uretrovesical angle elevated. This is called a Bonnie's test. Without elevation, the patient passes urine. When you elevate, the patient doesn't pass urine. This is how we will test. This is called the Bonnie's test. In the Marshall's test, bladder neck is elevated with open Aries clamp. Instead of putting fingers, we'll put a Aries and we open the Aries, two blades. On staining, absence of leakage of urine indicates positive test. Similarly, both are the same. That we'll do the Bonnie's test we'll do with the fingers, whereas Marshall's test we'll do with all these forces. Then you can do ureteroscopy. Inner information about opening pressure and uretrovesical angle will be able to know. Then rule out urethritis, diverticulosis, and rigid urethra. Urodynamic evaluation. Cystoscopy measures the pressure of the bladder and urethra during artificial filling with carbon dioxide or fluid. Then ureterocystometry. Normally at rest, 150 ml of urine causes 2 to 8 centimeters of water pressure. Uterine pressure average 40, average 40 centimeters of water lead to incontinence. When we put water and there is a pressure of 40 centimeters water leads to incontinence. By that we can make out the stress incontinence. Then other tests are uroflowmetry and, and micturition cystometrography. Then normally 100 degrees well marked posterior urethral is noted. When this angle decreases and comes less than 100 degrees posterior uretrovesical angle, then we will get loss of this angle will lead to stress incontinence. Uroflowmetry measures dynamic urethral pressures. Diagnosis urethral instability and divertical. Gold standard in diagnosis stress incontinence. Diagnosis urethral instability and divertical. With urinary flowmetry, dynamic when we measure the dynamic urethral pressure, we can diagnose urethral instability and divertical, urethral divertical. Then gold standard in diagnosis of stress incontinence. Then treatment, conservative and surgical repair. Conservative line especially young women, elderly and frail women unfit for surgery, and during 6 months after pregnancy and previous failed surgeries, and in case of distress instability, we treat conservatively with drugs. Then comes the physiotherapy, pelvic floor exercises for 4 months without electrical stimulation and weight loss and exercises. These will correct the stress to a certain extent. drugs, alpha magic drugs, bladder, decrease frequency of stress. Intraurethral and vaginal devices will cause the strengthening of the pelvic floor, thus the stress complaint may come down. And electrical stimulation to pelvic floor muscles will also be given to control stress impact. These are all the drugs and this physiotherapy, intraurethral and vaginal devices, electrical stimulation. These are all we'll do in a woman, young woman, and in an elderly woman where she is not fit for surgery. An artificial urinary sphincter in neurological condition and previous surgically failed patients. We go for artificial urinary sphincter. Then genuine stress and trauma in post-menopausal women with senile changes in the vagina, estrogen replacement therapy, and local estrogen cream. Treat chronic cough, constipation, allergic rhinitis. Vaginal operations are anti-calprotrophy, Kelly's repair, anterior calprotrophy with application of the bladder neck. As I told you already, this Kelly's repair, we do anterior calprotrophy. Then we'll identify the neck of the bladder. Then we'll placate the bladder neck on both sides, putting 2 to 3 sutures. Then facies repair, opposing medial fibers of tuborectalis muscle in the midline under bladder. And coming to the abdominal operations, this is modified Kelly's operation, where we have put stitch and when the posterior urethrovesical angle is obliterated by putting Kelly stitch, we could make the angle and thus the stress incontinence can be relieved. We are preventing posterior urethrovesical angle by putting a stitch. Then coming to the sling operations or all read sling operations, where we take a facial strips from the rectus muscle in a ribbon way with the 2 centimeters wide and will lift the strip from the lateral to the medial and will keep the medial end attached at the center on both sides and will bring those strips retropubically from rectopubic space, bring them into the vagina as I have shown here and plicate them and support at the mid-urethral level. It is called sling operations. It is called allied sling operation. This is how we will bring unity in the midline to form a facial sling beneath the urethra as it functions with bladder. Similarly, we can put the Mercilin gauze hammock, suturing the gauze in the position of the ensuring that it remains evenly spread. This is how we put Mercilin gauze hammock, vaginally supporting the bladder neck. Abdominal operations are Marshall-Marchetti Quain's MMK operation. Suture the bladder neck and vaginal wall to the periosteum of the pubic symphysis sac. This is called MMK operation or Marshall-Marchetti Quain operation. And the other operation is Birch-Calpo suspension, where we suspend the vaginal suspension using iliopectineal ligament or Cooper's ligament. Okay, here we'll bring the bladder neck. In the first surgery, MMK surgery, will applicate that to the symphysis pubis, periosteum of the symphysis pubis on back. In Birch-Calpo suspension, will applicate to the iliopectineal ligament or Cooper's ligament. The latest type of treatment is tension-free vaginal tear. This is Birch-Calpo suspension and Marshall-Marchetti MMK technique of surgery, where we fix it to the synthesis tube, here iliopectineal periosteum or Cooper's segment will fix it in Birch-Culper suspension. Here the bladder neck is elevated by stitching it to the urethra in the anterior pubic bone. Then we can do combined abdominal vaginal periara operation, laparoscopic Culper suspension, intravesical bladder neck application, periuteral collagen injection. Nowadays, the most practice is tension-free vaginal tape, which supports the mid-urethra and decreases the stress incontinence. What are the various surgeries we are doing for the stress incontinence? Complications of surgery. There is no surgery without complications, but you must try to avoid complications as far as possible. While doing these surgeries, you may injure the bladder and urethra, and a retropubic space hematoma can occur, and the infection, breakdown of sutures, voiding difficulties in retention, erosion of non-absorbable sutures into bladder, urethra or vagina, causing fistulas, infection, stone formation. These are the various complications of the surgery. Thank you. If you have got any questions, you can ask. Hmm? Any questions? Any doubts? You can ask. Any doubts regarding urinary incontinence and the stress incontinence? Yes. Thank you.